Hello and welcome to the second Transplant Australia COVID and Vaccinations webinar. My name is Holly Tyrrell and I'm a Director for Transplant Australia, and myself proudly to be fully COVID vaccinated as well as being a transplant recipient. After a huge attendance and overwhelming positive feedback following our first webinar we hosted earlier this year in February, we welcome you back again to continue the discussion and provide updates on the evolution of the research, insights and current practical advice for staying safe and healthy in the current environment. Transplant Australia is pleased that the majority of the general population have embraced vaccinations, as this helps keep recipients and our loved ones safe. Tonight, you will hear from an expert panel on the importance of vaccinations, boosters and personal protection, such as masks, specifically for transplant recipients and those on the waiting list. Leading tonight's expert panel will again be the wonderful Professor Toby Coates, AO, Director of Transplantation at Royal Adelaide Hospital. And Toby, I'll now hand over to you to get us started for the evening.
Thanks, Holly. It's again great to be here and be able to talk to everybody about a vaccination. I'd like to start by acknowledging that I'm meeting here on the lands of the Kaurna people of the Adelaide Plains and pay my respects to their elders past and present. Going forward, this is a very important topic, talking about vaccination for COVID-19. And the reason that it's so important, of course, is that this is a respiratory infection. And so having a vaccination that prevents a respiratory infection is the principal way that we can protect ourselves and community against this particular infection. I'm very excited with the panel that we've got here tonight because we're going to hear from the real cutting edge, the people who've been involved in the front line of this in Sydney, and also experts from the front line in Melbourne for discussion with all the craft groups that have been involved with managing COVID-19. So without too much more of an ado, I think we should crack on. We want to have maximum time for questions. We've been, as Holly said, inundated by really good questions that we want to spend time discussing in the panel discussion at the end. So without any further ado, I'll introduce Professor Steve Chadbang. Steve is the Director of Renal Medicine at the Royal Prince Alfred Hospital and has been chair of the task force which we set up with TSANZ and the Organ and Tissue Authority to help manage the COVID-19. So he's really been in a pivotal position, involved in policy dealing with this. So I think it's great to have him from the front line as well. So Steve, I'll hand over to you without any further ado.
Toby, thanks very much for that kind introduction. I'll just take a minute and share my screen. And where I was going to kick off was to follow up from the original talk we had in February, and I'll just try and get this one onto a full screen projection. Not really happening there for me. What I was going to touch base on was firstly kick off with my concluding slide from that talk back in February. And back in February, I think you'll recall, we'd just endured our first wave of COVID. It was the traditional strain, it wasn't a variant. And we'd seen around 2 million deaths globally. In Australia, we thought we were on top of things. And at that stage, we thought, however, based on our international experience, that COVID-19 was actually a big problem for kidney transplant recipients, liver transplant recipients, heart and lung particularly. From a general population perspective, we felt that COVID-19 vaccines work well as far as we could tell, but we didn't have that much data. And in particular, from a transplant perspective, we hoped that the vaccines would be safe and effective. And the little data we have suggested they were, and so we did suggest vaccination. So what I wanted to do is touch back on these 3 points and see where we're at now. We're in July, and what we have seen is, Kim, if you could advance that slide for me, please. In July, we now have the sobering information that 5 million people globally have died for this. And as we all know here, and particularly those of us from Sydney or Melbourne, we've just endured our second wave, and this was Delta. It was different. What that's meant for us is that our first prediction that COVID-19 was a big problem for transplant recipients is true. If we look at the general population impact, we have a population of 26 million people, of whom 172,000 have been infected, which means that a little under 1% of everybody in our community has been infected with COVID. This has exacted a toll, and that 1% of those people infected among the general population, or 1,700 Australians, have died from the disease. If we look at our transplant population, and here I have kidney transplant data because we have the best data for our kidney transplant recipients. We know that we have a little over 12,000 kidney recipients. Of those, 68 have been infected with COVID, which is very similar to the infection rate among the general community. What's very different, though, is that 10% of our kidney recipients succumbed to this disease and died. So for transplant recipients, the risk of infection is the same as everybody else, but they're 10 times as likely to die from COVID if we get it. Next slide, please, Kim. So the second point we made was that COVID-19 vaccines seem to work well as far as we can tell in the general community. Now, of course, we have a lot more data, and I think we can say with great confidence that the COVID vaccines, Pfizer, AstraZeneca, and others, do reduce duration and severity of illness and do greatly reduce the risks of transmitting to someone else. And this is a key reason that we're promoting what we call ring vaccination, that Toby will come back to later. The concept here is that if everybody in your household is vaccinated, their risk of bringing COVID into your home and transmitting it to you is greatly reduced. This is a key point. We also know that in the general community, the vaccines do reduce the risks of severe and fatal COVID infection. But from some data that I'll show you in a moment on the left-hand panel here that only arrived a week ago, we do know that the effectiveness does wane from about 6 months on. And if I can show you this small slide on the left-hand side, this is a study from Israel where they looked at how many cases of COVID occurred in June and July of this year. And the left-hand panel shows me cases of severe COVID. What it shows is that people who had been vaccinated 2 or 3 months before were very well protected. By comparison, those who'd been vaccinated 6 months before or earlier were 3 times as likely to suffer from severe COVID. So the effectiveness of these vaccines does wane. Even for members of the general population, a booster is required. And I think you'll soon see that the Australian government rolls out vaccination across the general population in terms of a booster shot. Next slide, please. So what does it mean for transplant recipients? We felt that the early data suggested effectiveness and safety. And I think we can now confirm that to an extent. In the transplant population that we've seen, all of the vaccines that are available in Australia do appear to reduce duration and severity of illness, do reduce risks of transmission, and do reduce risks of severe and fatal COVID. And the best data we have from this comes from the UK, where very large numbers of people have been vaccinated, and the government compared their registries of vaccinated versus unvaccinated transplant recipients. And here they had in the order of 70,000 patients to look at during a very bad epidemic. And they showed that vaccination reduced risks of hospitalisation by 10-fold and reduced risks of death by 10-fold. Very worthwhile having vaccination. We believe the vaccines are safe among our transplant populations. They have not been associated with rejection across a very large number of people, nor have they had any particular other effects any different to the general population. The thing we've recently realised, however, is that most people need 3 doses. The graph on the left-hand side shows you the proportion of transplant recipients who'd received 1, 2, or 3 doses of vaccine and showed you what proportion of them are adequately protected. And what you can see there is that after a second dose, approximately 40% only of people have adequate immunity as far as the blood tests show against COVID. The third dose, if you like, increases that proportion to about 70%. 2 messages here. Transplant recipients really do need a third dose, but even after a third dose, a third of people will be probably inadequately protected. So we really need to continue all the usual measures of hand washing, mask wearing, and social distancing. But let's think a moment about why we need 3 shots. Thanks, Kim. Next slide. When we give a COVID vaccine, it's really like an injection into your immune system. Your immune system responds in 2 ways. It produces B cells that produce antibodies, and the antibodies are circulating in your bloodstream so that whenever virus enters your bloodstream, they're designed to mop up that antibody and prevent it from it getting into your cells and causing infection. They have a second arm, and that is the T cell response. T cells are designed to look for any of your own cells that become infected with virus and to wipe those out. So that in a combined way, the antibodies and the T cells eliminate virus from your body very soon after it enters it. In this instance, the immune system wins over the virus and you get relatively mildly sick only. And this is what happens in the vast majority of the general population who are vaccinated. Next, please, Kim. However, when we come to transplant recipients, what happens is very frequently we don't produce enough B cells and enough antibodies in response to a COVID vaccination. And similarly, we don't produce enough T cells. What this means is that if the virus does enter the system, there isn't enough antibody nor enough T cell to eliminate the virus quickly, and the risk of severe disease is much greater. Next slide, please. Why does this happen? Well, I think that we've all understood that taking immunosuppressive drugs, mycophenolate, tacrolimus, cyclosporin, prednisone, and others, are designed to reduce your immune system's response against your transplanted organ. Unfortunately, this also reduces the response to viruses. There are other things, however. If your kidney function is reduced, if your liver function isn't up to scratch, if you have heart problems or diabetes, all of which are very common among our transplant patients, these also reduce your immune system's ability to respond to a vaccine. A more novel thing that we've noticed is also that your gut health is critical for healthy vaccine responses, and gut health is often poor among transplant recipients. Next, please, Kim. So what can we do about this? The answer is we don't know, but the better answer is that we're conducting some research to try and find out if there are ways that we can help your immune system mount a better response to a COVID vaccine. And in a trial that kicked off yesterday in Adelaide and will kick off in a couple of days' time in Sydney, led by Toby and myself, we're going to test out a couple of those possibilities by either altering the drugs that people are taking to see if this improves response, or in another arm, by giving a dietary supplement to provide fiber to the gut, improve the health of the gut bacteria, and thereby hopefully improve the immune response. If you're a patient and you're interested in participating in this trial or even finding out more information, please do take a shot of the screen and scan in the QR code. We can provide you with this information after the talk. Thanks, Kim. So I'd like to close just with the last slide there. The take-home messages have gone, but I think you've got the gist of it. I think that it's critical to get vaccinated, to get a 3rd shot, to get your family vaccinated to provide you ring vaccination protection. But in the meantime, also continue hand washing, do wear masks and minimize your risk. A lot of this data comes from a lot of people, and I would like to just thank the members of the National COVID Task Force who've really run a good strategy and helped us deal with this, this pandemic in this country very well. I'd like to thank my team and the Revastin team at both RPA in South Australia, and also thank Transplant Australia, and in particular, all of my patients for motivating us to do this work. Thank you.
Fabulous. Thanks, Steve. That's a beautiful, comprehensive overview. And I think that last slide really says it all. That's what we need to be doing. And hopefully by doing all those things, we'll minimize the impact on our patients. So Steve's talked to you about the vaccination. And that's clearly the most important strategy, as I said at the beginning, for respiratory infection. If we can provide a vaccine that prevents a respiratory infection, then that's a good way to go. But also the other side of that, and I'm sure the people in the transplant community will have heard about this, is there have been a number of new medications that have come available and have been used in New South Wales to help treat people when they get these infections. And we're really privileged tonight to have Professor Jermaine Wong, who's the Director of Renal Medicine at the Westmead Hospital and also the Director of the Kidney and Pancreas and Islet Transplant Unit, to be able to talk to us now about her involvement, really again at the front line, and also some of the experience that she's had using some of these medications to treat people who unfortunately, despite everything that we can do, end up getting COVID. So I'm really excited and looking forward to hearing what Jermaine has to say. So Jermaine, over to you.
Thanks so much, Toby. I'm just going to show and share my slides. Could you see them? Well, yes, good. Excellent. So thanks so much for the introduction. So this is what we're going to talk about today on the our experiences of COVID-19 in the Western renal service in Sydney, and also some of the emerging treatment for COVID-19 in our kidney disease patient. So and a little bit about the impact of COVID-19 on the transplantation services. So just a brief introduction into the incident COVID-19 cases across New South Wales during the July to October pandemic. As you can see here, during the highest numbers, the period between July and October, southwestern Sydney and Western Sydney experienced the greatest hit. On a daily basis, we have about 500 cases during that time. Also, just want to show people the demographics of Western Sydney to understand why that we have such a large number of incident cases. Western Sydney is a culturally and ethnically diverse population. 54% of our population have household members who are non-English speaking. It is also quite densely populated compared to the rest of the state, and also have a higher unemployment rate compared to the rest of the state. During the July and October period, we have had about 6 active outbreaks across the Western Renal Service. And Westmead Dialysis is the only treatment centre for COVID-19 positive patients within the Western Sydney LHD. These are the characteristics of our patients with kidney failure and COVID-19. Our mean age is about 58 years, with the youngest being 22 years old and the oldest of 89 years. Relatively skewed, you can see the population. The majority of our patients with kidney failure and COVID-19 are male, and the majority were on dialysis. About 16% had a kidney transplant. At the start of the pandemic, within our local health district, the vaccination uptake is low. The majority of patients with infection had either none or only 1 dose of the COVID-19 vaccines. This is some of the data of our dialysis patient. We have 32 patients on dialysis with COVID-19. 50% of our patients required hospitalization, and 20% of these patients who have been hospitalized received some form of supportive therapy, such as the very high dose steroids called the dexamethasone, and also the antiviral medication to kill the virus called the remdesivir. In August, mid-August, that was the special monoclonal antibodies was approved by the health minister, and we're very fortunate to receive the first 500 doses of the monoclonal antibodies called the sotrovimab. In our dialysis population, 34% of those had sotrovimab. In terms of the outcomes of all our dialysis patients, unfortunately, 20% of our patients died. Approximately 13% required ICU admission and also mechanical ventilation. Our transplant population, these are solely kidney transplant recipients. We did not have any patients with a kidney and pancreas transplant had COVID-19 during this period. Again, the hospitalization rate is high, about 50% of those patients. They also received supportive therapy, the steroid, and also the antiviral medication. Thankfully, unfortunately, we had no deaths, but we did have quite a high proportion of patients with the COVID-19 and kidney transplant admitted to ICU and required ventilation. The good news is that of the 15 patients that we had received the sotrovimab, none of them died from COVID-19, and that was given pretty much at the early stage of the disease. Just want to emphasize that vaccination saves lives. You can see here the majority of patients who died were neither vaccinated or only partially vaccinated. So in terms of our experience with treatment, there are two major types of treatment. One of those target the actual virus itself. The other types of treatment target the inflammatory response generated by the virus, responses that can cause the damage to the lung and also to the kidney sometimes, and also to the brains. I urge our audience to visit this very special website. It's funded by the Commonwealth in collaboration with the Cochrane Library to produce the most up-to-date information and evidence to inform the treatment guidelines used by the Commonwealth and also the state government. And most importantly, there is also a consumer version of this, currently only in English language, but it's been going to be translated into multiple other different languages. So today, just going to briefly talk about a couple of the disease-modifying agents that we have had experience with. One of those is targeting the virus, and this is the special protein inside the virus called the remdesivir. From the trials or research that overseas units have performed, we have found that there are fewer deaths in patients with COVID-19, fewer needed invasive ventilation, and fewer of our patients needed adverse effect. The other types is previously mentioned is the monoclonal antibodies that called the sotrovimab that targets in this very special orangey area outside the actual virus called the sotrovimab epitope. The indication currently in Australia are for high-risk patients, certainly our patients with kidney disease, those on dialysis and who have received a transplant. Other risk patients include people who had diabetes, lung disease, and who are obese. Now, this is given at the very early stage of the disease and must be given within 5 days of the symptoms onset. And you can see in the actual guidelines is that it is only for unvaccinated patients. In our centre, we argued that all of our patients, unfortunately, potentially have poor response to the vaccines. So we were able to provide our patients with these monoclonal antibodies regardless of their vaccinations status. And this is a very recent trial published just, I think, last week, looking at the benefits of this special treatment for patients with COVID-19. What they found that compared to placebo, which is people that have not received the treatment, there were no deaths, and that also a substantially reduced percentage of hospitalization. We gave it as a single infusion. We've done it initially as an inpatient, but it's been given widely in our transplant units with very minimal side effects. It took about 30 minutes to infuse the infusion. So last but not least, just briefly go through the global impact of transplantation rate during the specific pandemic. The figure on the right shows the number of COVID-19 related deaths increases, and you can see the greater number of reduction in the solid organ transplantation rate globally, and that was published again recently. We didn't have much data in Australia, partly because we were not part of the earlier pandemic. But it has hit very hard, as you can see, in the United States and also in Europe. And that equates to approximately 48,000 life years are being lost during this time. So in summary, cannot emphasize more, the vaccination saves lives. Mortality rates in our dialysis population is high. It's about 20%, very much similar to what is being published. We're very thankful that there are no deaths in our transplant population. However, the hospitalization rates for our patients with kidney failure, both on dialysis and patients who had received a transplant, is high. I can't emphasize more the benefits of the treatment that we've given with the monoclonal antibodies. Totally anecdotal. We have only 15 patients, but we have had very good outcomes. So that's all from me. Thank you.
Fantastic. Thank you very much, Jermaine. It's wonderful to see that experience that you've had at Westmead. I think it's really reassuring for all of our population to know that science is producing these great medicines that we can use if we're not able to infection. So that's wonderful, and thank you very much for sharing that with us. It's a quite unique experience. So we've heard from two kidney experts. Jermaine is also an expert epidemiologist as well, so you've had that epidemiological perspective to managing this condition. What we'd like to do, and what we discussed with Transplant Australia, was making sure that we covered all of the other organ groups as much as we possibly could. So it's a very great pleasure now for me to introduce Associate Professor Simone Strasser from the AW Morrow liver transplant unit at the Royal Prince Alfred Hospital. She's an expert liver transplanter, and so she'll be bringing us up to speed with how COVID-19 and the infection there, and particularly from the Sydney point of view, has impacted liver transplants. So Simone, can I throw to you now to hear your presentation, please?
Thanks, Toby. It's a great pleasure to be here and to talk about some of the liver aspects of what we've been seeing as well. And I know some of my patients are certainly in the audience tonight, which is excellent. So I did want to just look at specifically about and provide a bit of uptake what we've been seeing in Sydney with this most recent surge in cases. This is actually some experience from internationally. And this was a recent review where they pulled together 18 articles that included over 1,500 liver transplant patients and compared them to 240,000 non-liver transplant patients and looked at some of the impacts. Now, we know that people with cirrhosis, this isn't transplant, this is people with liver disease, do very, very badly if they get COVID infection. And the death rates if you've got cirrhosis in a pre-transplant setting, somewhere between 30 and 42%. And that's through both lung failure and liver failure. In transplants, it's a bit different though. So 23% of liver transplant recipients will develop severe disease. And hospitalization rates are high, probably because we have a low threshold for putting people in hospital. But the ICU admission is not higher than for the non-liver transplant patients. So while we might put more people in hospital to care for them, they don't end up going to ICU any more than non-liver transplant patients. Furthermore, from this review, the risk of dying from COVID was comparable between the liver transplant and the non-liver transplant patients, and it was around 17%. And what it was really the underlying comorbidities that we talked about earlier, which is high blood pressure, diabetes, and obesities, which are much more common in liver transplant recipients. And they're probably what's driving the increased risk of severity and death from COVID, rather than being a liver transplant patient per se. Now, we recommend COVID-19 vaccination for all patients on our liver transplant waiting lists. So while their immune system is probably not quite as good as normal in cirrhosis, but it probably dips lower after transplant. So certainly we want everybody on the waiting list vaccinated while they're waiting for transplant. And everybody who's had a transplant, we're clearly recommending COVID vaccination for all transplant recipients, particularly our liver transplant recipients. There's no specific recommendations regarding which vaccine to have. And as you've heard, we strongly recommend the third dose of the mRNA vaccine 2 to 6 months after the second dose. Now, vaccination's been available for our transplant patients, in fact, since March earlier this year, where transplant patients were included in the phase 1B, if you remember when the phases were initially rolled out. Because of the lack of vaccines available in the country, we had to go in phases. And solid organ transplant recipients who were on immunosuppressive therapy were in that first wave. However, many were slow to take up the vaccination. And so again, this is another way of looking at the figures that you just heard from Jermaine, but in New South Wales, between June and October, we saw nearly 66,000 locally acquired cases of COVID, which was obviously, a sudden surge of all those patients. And unfortunately, there were people at that point who were unvaccinated. And so we've had in our transplant unit 14 patients diagnosed with COVID. 10 of those were post-transplant and 4 were patients with chronic liver disease and with cirrhosis. And you can see here that amongst those 14, 8 of them were unvaccinated, 2 had had a single dose, and there were 4 who actually got COVID who had had 2 doses of vaccine. And again, going to what Jermaine was saying, where the surge particularly happened in New South Wales, it was those high-risk LGAs in southwest and Western Sydney, and that's where most of our cases came from as well. So there were 8 cases from there, 2 from the central LGAs and more around RPA. We had 3 from Greater Sydney, but in the non-metropolitan area, so mainly from the Central Coast, and we had a regional patient as well. So we had 10 liver transplant patients with COVID in this most recent outbreak, median age 57.5, half were women, half were men, and 5 of those 10 were unvaccinated. And we've got documentation that we had discussed vaccination with all of them, and it's been a routine part of care all year, talking about vaccination and dealing with issues around why people didn't want to get vaccinated or didn't think they needed to get vaccinated right now. They might wait and see. And of course, by the time the surge happened, it was kind of getting a bit late if you hadn't had your first vaccination. So again, 2 had had 1 dose of our 10 transplant recipients, and 3 had had 2 doses and still got COVID. And in terms of immunosuppression, 1 was on no immunosuppression at all, and that occasionally happens in liver transplant, and the majority were on 2 agents. And there was a background of comorbidity, diabetes, kidney disease, and 2 people were smokers. So in the majority, transmission was through household contact. So our transplant patients have been really good at isolating at home, not going out, not exposing themselves to the general community. However, many of these people live in households where there's a lot of people living in the house. In fact, 1 had 8 people living in the household and none of them were vaccinated. And it was another member of the family that brought the virus into the family. So this gets to the point that Steve made earlier about making sure that everybody's vaccinated to protect the transplant patient who may not mount a good level of immunity. So at the time of the first test that was positive for COVID, all had respiratory symptoms, although they were usually mild, and 7 of the 10 had a fever. By the time, as you heard, from about August, September, we had access to sotrovimab, and that was given to 4 of the patients after it was available. And we gave it in various settings. 2 of the patients had it at home, 2 were in hospital because they were already in hospital for another reason. And also 2 were not in the metropolitan area and they managed to get it at home very quickly. So wherever you are in the state or in the country, you should be able to get access to sotrovimab in a timely fashion. And our patients with COVID didn't get any significant problems with their livers. Now, I focused here on the 10 liver transplant patients. 5 of them ended up in hospital. 5 were managed just at home through the support that was given through virtual hospitals and through other ways. And you can see here the breakdown of the 5 hospitalized patients. 2 of those were actually fully vaccinated and 3 were unvaccinated. And of the non-hospitalized, 2 of those were unvaccinated. So these patients, one of them ended up in hospital for 18 days, and that person actually was in the intensive care unit. He actually did get sotrovimab, but he didn't present until he was already 8-9 days after the onset of symptoms, so it was too late really. And he ended up in ICU and quite sick with pneumonia, but has survived and is out of there. 2 people just needed some oxygen through nasal prongs, but recovered, and no patient died, fortunately, of this experience, which is good. So I really just wanted to give you that really brief update of what's happening in New South Wales. In Victoria, they have had 3 or 4 of their transplant patients in the most recent surge in Victoria with COVID. And I believe there's been 1 death in Victoria related to pneumonia. So important messages from me. Make sure you attend your regular follow-up. So if you're fixated on COVID and too scared to come for follow-up, you're at risk of getting other problems related to your transplant or to your other disease processes. So make sure you're having a regular follow-up, take regular medications, eat well, exercise, get vaccinated, have the 3rd dose, and the boosters when they're available as well, and if they become available, and particularly help your family get vaccinated. And while the transplant patients we've found are quite keen to get vaccinated, the family around them may not be getting vaccinated, and everybody has to be to protect our transplant patients. Follow all the health advice. When you are returning to work, and we hope you do, or education facilities, make sure they are COVID safe if you're returning there, but really encouraging people to get out now that we can. Get tested if there are symptoms, and if you are diagnosed positive, get in touch with the transplant unit if no one's talked to you about sotrovimab particularly, because that's got to be administered within 4 or 5 days. So thank you, Toby. That was all I really wanted to cover from the liver transplant point of view.
That's absolutely fantastic, Simone. It really reinforces all of the things that you've heard from Steve and then from Jermaine, and that unique experience about using the monoclonal antibodies to treat is so powerful and so useful, and so good to know that it's there. And that message that you had about making sure that if you've got the symptoms that you get in and get tested so quickly is very, very important. So what I'd like to do now is quickly talk to you about the panel. We recognize obviously that there's not just livers and kidneys, but there's hearts and lungs that have been transplanted. And I'm sure in our audience, we'll have people from the heart and lung community as well. So we're really, really privileged in Australia to have outstanding heart and lung transplantation professionals. In addition to the world-class experts you've just heard, we have joining us tonight on our panel, Professor Peter McDonald, from the Victor Chang Cardiac Transplant Institute in Sydney, but also from Victoria. We've also got Professor Greg Snell, who's one of the international leading lung transplant physicians in the world, really pushing the boundaries and providing excellent care. So what I'll do very quickly is just get them, I hope, to maybe say hello and perhaps give their very quick message about care. I'll start with Peter, I think, first, as I did see him on the call. Peter, would you like to say something about heart transplants in the COVID outbreak that we've experienced so far?
Well, first of all, good evening, everyone. I'm currently in a little farm in northern Victoria on annual leave, and I don't have any slides. But from a heart transplant perspective, there's been 5 confirmed cases of COVID-19, 3 of them in New South Wales and 2 in Victoria. The 2 of those, one patient was fully vaccinated, another patient had the first dose of vaccine, and 3 were unvaccinated. The ones that were fully or partially vaccinated had mild illnesses and did not require hospitalization. Of the 3 that were unvaccinated, all 3 were admitted to hospital. 2 of those were in Melbourne and 1 was at St Vincent's in Sydney. And sadly, that patient died. So he's been our mortality related to COVID. So that's 1 in 5 or 20%. And if you look at the worldwide literature on heart transplants and COVID infection, the mortality has been 20%. Now that's prior to the advent of, effective antiviral therapies. But I think heart transplant recipients are a particularly high risk group. And the other thing to mention about all 5 of these patients, they were years out from their transplant. So they were not sort of within that sort of high risk, first few months post-transplant. We recommend that all patients who have been transplanted or who are waiting for transplant are fully vaccinated. And that's certainly being rolled out at the moment. There have been a few patients who've been vaccine hesitant, and that's that's dealt with on a case-by-case basis. But I think particularly with these large-scale outbreaks in Victoria and New South Wales, there's been a very rapid uptake across the transplant community and the waitlist community. I'll stop there and happy to take questions.
Thanks, Peter. Fantastic. I'd like now to ask Professor Greg Snell from the Alfred to give us the perspective from the lung transplant point of view. Greg, can you tell us your experience so far from the Melbourne outbreaks?
Yes, thank you for the opportunity to just show a couple of slides. just four slides and four points. The first is that we have quite a solid database with email addresses, and we did a survey that was essentially 5 weeks or so ago, and we had an excellent response to the survey and noted that we had in all 99% of the people were either vaccinated or planning to be vaccinated. The majority with AstraZeneca, which I think was evidence that both of the population age, but also that people had got in fairly early with vaccination. We noted equal side effects in each group, and out of the 380 odd patients there was only 2 cases that had one night in hospital, one for dizziness and one for some palpitations, and there were no significant problems with that. And I thought, as a testament to the vaccination, in nearly 400 patients, we had 99% of them who answered the survey said they would have a 3rd dose, and that struck me that people were taking it all seriously, and that the vaccination hadn't stopped them in their tracks. And there was no rejection. The second point I wanted to make is about the COVID results in the lung transplant patients across Australia. There's been 6 cases. One last year had tummy symptoms and fatigue, and that was it. The lungs never got into trouble. 3 have had cold-like symptoms, and there's been 2 pneumonias and 1 death. And of the people in recent era who could have been vaccinated, the death patient was one who had a single vaccination only and was hesitant about the second one. And I think the rest have all had, all the minor ones had been double vaccinated. And this is actually only half the rate of the general Australian population. So I think that the lung patients have been hiding well, I think, across the country and being obsessive, which is great. The next point I want to make out was that we've got our clinics and our telehealth, but we're missing all sorts of medical issues and stress. And Simone made the point that you've got to turn and think about all the other things that COVID does. And I think we'll find in the next 2 years that it won't be COVID that's the biggest problem as such. It'll be the other peaks of the urgent diseases that people ignored, the bleeding from the bowel and the chest pains and the diabetes and things. And we'll have troubles with people getting sick over the years to come because of the missed 18 months. And of course, not to mention the stress. So I think these are really important things to think about, that we've got to look at the whole picture of looking after people with chronic diseases. And the final point that I think we need to say is that the vaccination, we believe, is essential, and it's indeed mandated. And in Victoria, all hospital staff have to have it. All visitors now have to have it, including the carers, double vaxxed. And all of the Australian lung transplant patients have independently decided that all waiting list patients would need it. And I've briefly listed some reasons there as to the main points. But of course, lung patients can have lung symptoms, so they could be confused with COVID. You're in the wards and the intensive care, you're in contact with a lot of staff. You could give COVID to somebody else. You'll get a better response to the vaccination before. And at the end of the day, it's one of many things we ask of people to get a successful transplant. So I just wanted to make those points. Thanks, Toby.
Thanks, Greg. That's an excellent summary, and I think you can see all of the experts really saying the same messages. The priority is getting vaccinated, but the good news is that we do have these extra supplementary treatments if we need them, and that's a fantastic healthcare system that we live in. We're really privileged to be living here in Australia. I'll just very quickly flick to Peter McDonald again. Peter, Greg has just left with that position of vaccination to be on the waiting list, because that's one of the questions that's come through on the question line. Is that the same for people who are having heart transplants? Could you quickly comment on that for me, please?
Yeah, look, I think up until now, we've recommended that everyone on the wait list be vaccinated. It's now essentially become mandated. We've had one patient on our lung wait list who wasn't vaccinated, got COVID and died as a consequence. So the consequences of not being vaccinated, they're such a high risk population. We feel that given the scarcity of donor organs, we have a requirement to ensure that if we do utilize an organ, it's going to be in a person who's going to have a good outcome. And if someone's unvaccinated against COVID and it's so prevalent in the community, that's just another, adverse risk factor. And, I think, as I say, we've now essentially mandated that everyone on our wait list needs to be vaccinated against COVID. And I think that's become the policy of all the heart transplant programs across the country.
That's very helpful. Thanks for that. I'll very quickly ask Simone from the liver point of view, what's happening in the liver units? Is that the same policy happening there?
We haven't mandated it, but we've strongly recommended, and in fact, all of our waiting list patients are vaccinated. So they're listening. The majority of our post-transplant patients are also vaccinated, but there are a few people who are hesitant to get vaccinated for various reasons, which we can perhaps discuss. But and of course, we're continuing to strongly encourage vaccination, but there are some people who don't want to be vaccinated, but it's not our waiting list patients. I think they're all very motivated to be vaccinated. I don't know what the situation is in the states where there's less COVID, and I would strongly encourage people from those states, WA, South Australia, Western Australia, and Queensland particularly, to make sure that they've seen, they look at what's happened in Victoria and in New South Wales and get in ahead of it, because it's kind of inevitable and you want to be vaccinated now. So I don't really know the situation in the other states, but I would strongly encourage anyone who's waiting for a transplant or has been transplanted to definitely get vaccinated.
That's very valuable, and I completely concur with that. We've got so many questions and we won't have enough time to get through them all, unfortunately. It is fantastic to have our transplant community asking questions, and we'll do our best to answer as many as we can. I'd like now just quickly to go to Jermaine and ask her first, just quickly about if you could just comment on the vaccine on the waiting list. But secondly, one of the questions that's come across is, what is the process we follow if contracting the virus after a transplant? And I think your insight would be very helpful, Jermaine. Can you let us know what you think, or what your advice would be, please?
So just the first question, thanks, Toby. In terms of the waiting list, we haven't mandated it, but we strongly recommend both our kidney and also our kidney pancreas transplant recipient, and strongly recommend the third booster dose currently. It's really hard to mandate vaccination for our patients, but we all understand there's an urgent need to get that third dose. In terms of the treatment for our patients, or the experience, the process of having COVID-19 in transplant recipients, so we are very fortunate to have a very isolated area within our clinic. So all positive patients who have had a transplant do have that special area to come through to our unit in an isolation room. Now, obviously, if they're well enough, they can go home. And they may monitor them on an outpatient basis. But you can see with our data, approximately 50% of those had symptoms, and most of those we admit them into our COVID-19 wards and institute the treatment if they present early. And thankfully, most of them presented early with the monoclonal antibodies.
Thanks, Jermaine. Lots of questions to get through. So one of the really popular ones that's come across, and I'd like to perhaps ask this one maybe of Steve Chadban, is which booster is preferred, Pfizer or Moderna? And secondly, another one that's come through quite frequently is there any evidence of increased rejection after vaccination? Steve, what are your thoughts on those?
The first answer is no evidence of rejection after vaccination across all of the organs. And I think the other guys commented on that as well. That's very reassuring to us. Which vaccine? I don't think there's any evidence that suggests that any of them are superior to the others. We have seen good data that AZ, Pfizer or Moderna all work effectively as the third vaccine. It doesn't matter if you swap to an alternate vaccine that is different from your first two. But I think if you tolerated the first two doses of your chosen vaccine, I would probably have the third dose of the same. And that's what I did this morning at RPA. And so I think we can proceed with confidence with all.
That's excellent. There's another very good question that's just come through for one of the patients who's on the waiting list and is on dialysis. And he's asked whether or not he's having his COVID vaccination shot on Monday, and he's having dialysis on Tuesday. So I might just ask Jermaine again, is there going to be any problem with those antibodies being removed by dialysis, or can you confidently go ahead and have dialysis the next day after you've had a vaccine?
A great question, Toby. The pharmacokinetics of the sotrovimab, it hasn't actually been completely teased out in dialysis population. From our experience, there's absolutely no problem. So the stat dose of 500 milligrams of infusion for everybody, there's absolutely no issues with the sotrovimab. Now, there is a problem with the remdesivir, so because it is also partially renally excreted, and we had the very first experience is that one of our patients, we have given a little bit too much and causes the coagulation problems. So we're very cautious with the antiviral remdesivir, but we had no problems with the monoclonal antibodies.
And perhaps Steve Chadban again, just quickly, if you've had your vaccine, is that going to cause a problem with dialysis, that if you have the vaccine and then dialysis the next day?
No problem at all, Toby. In fact, we took all of our 32 patients on dialysis and vaccinated the whole lot each dialysis session. So we ensured that we vaccinated everybody, and it's worked well.
I might now go to Greg Snell again. Greg, you're a unit that takes care of a lot of transplant patients really across the country. Many people come to the Alfred to get lung transplants. So we've had a good question here is, how easy will it be for regional people to get access to a third vaccine? Have you had any experience with that, Greg?
I think the chemists are running with it in some of the state vaccination centres, and they've actually tended to have at times some spare supply over. So I think that's going to be relatively okay to get. I don't think supply is going to be too big a problem. And the transplant patients are right at the front end of it before all the healthcare workers and the like. So I think it should be good.
That's excellent. So there are some other very good questions, like what are the practical real life ways to stay safe in our daily lives? So I think that's very general questions. And I might ask Simone, from the liver transplant point of view and the general transplant point of view, what advice would you be giving to all of our listeners with this?
Well, yeah, there's a lot of ways of answering that. First is the family and getting everyone vaccinated. I think that's really, really priority. And that as people become eligible for the booster, that they get vaccinated with the third shot, and the transplant patients get their third shot 2 to 6 months after. We are opening up, and New South Wales, we're opening up really, really quickly. And I think it's time for everybody to start getting out there and getting back to normal. And that the question of how that looks, I think we all should probably be wearing masks for a while still, but particularly our transplant patients, and they should still be avoiding crowds and public transport for a while if they're crowded as things open up. Travel, we'll have to see what happens with that. But really, by the time people have had their third vaccination, the coverage is pretty good. We don't have antibody testing available routinely in Australia, so we don't know how good it is. And as Steve pointed out, it may only be 70%. So we don't know whether people are fully covered. And I don't think we can give really good advice about travel, particularly internationally at this moment for our transplant patients. I'd be a little bit anxious about that, but certainly regional travel, I think, will be opening up. Going back to work, a lot of our transplant patients have got school-age kids, and we're very worried about their kids going to school and continue to be. And of course, we don't have for the younger children, we don't have vaccines yet. And there's still a lot of anxiety, and I don't think I know the answer to that either at the moment. About what risk that poses to transplant patients when they've got kids who are going to school who are, 5 years old, 7 years old, or whatever, where there will be outbreaks of COVID, I think, inevitably. We don't have the answers to all of this. And I think what's important is that we talk about it, we get the data, we really track what's going on, and we make our advice sensible. And again, if people are diagnosed with COVID, they get diagnosed early, get symptoms, get tested, and contact us or the local public health units to get onto treatment really early and prevent severe illness.
Thank you, Simone. That's fantastic. And it's a very nice segue. You've covered a number of questions that people have actually sent through. So that's great. I'd like to flag also that Transplant Australia has got another webinar that's going to be specific, I think, for the paediatric group. So there may be some further insight that will come for that. So again, watch this space, and we'll try and feed back the information as it comes real time to everybody. I'd like to ask Steve now, because again, we just touched on the issue of antibody testing, etc., which, as Simone says, we don't have, so we can't actually routinely go and do this. Steve, one of the questions that's come through is, am I able to take part in anything that might generate data, re-transplantees and COVID research? So you mentioned the Riverston trial. Would you like to just talk a little bit about that for a moment?
Absolutely. That trial that Toby and I have kicked off this week was looking at people who have a kidney transplant who've had 2 doses of vaccine, and would like to know, firstly, whether they've had an adequate response to those 2 doses. And if they haven't, we would then offer participation in a randomized trial to either modify their immunosuppression slightly or leave them on their usual immunosuppression and give a 3rd dose of vaccine and look at the response 6 weeks later. Alternately, in a parallel study, we can offer, if they also have inadequate protection against COVID, we can offer you a dietary supplement for 4 weeks before your 3rd dose of vaccine, and then again look at what response is achieved. I think the nice things about that, Toby, are that we're hoping to find a way to improve the chances of our patients getting adequate protection through vaccination. The second point for people who do actually involve in the trial is that they'll understand more about their specific immune response to the vaccine. Is it adequate or is it not? And what can I do about it? That's really open to people who can access Adelaide or Sydney, but we'd love to talk to everybody. We've provided the link that can give you more information about that trial, and hopefully we'll get this done quickly and be able to give the message to everybody and hopefully help all patients through this mechanism.
Thanks, Steve. Jermaine, one of the other really frequently asked questions, and I hope you'll be able to help us with this, because we may not know the answer, but people are being asked, does it look like we shall need more than 1 annual dose of a booster COVID shot in years to follow? You're a fantastic epidemiologist. What do you think? And transplanter, what's your take on it?
Oh, thanks so much, Toby. This is such a difficult question. I think we have no idea really whether there is some additional benefit of boosting multiple times. As you know, certainly there is data in our transplant population from Canada and also the US, the benefits of the 3rd dose that Steve has shown, even in our transplant population. But whether we boost the 3rd or 4th, we have no idea. You've done some wonderful research, Toby, looking at boosting and the immune response. So I'll be very interested in seeing how that plays out in humans and, transplant patients. Yeah.
Excellent. We'll go for a little bit longer because I think we've got a bit longer, and I've got at least 68 questions on the chat line. So I'm really sorry. There's absolutely no way that we'll be able to get through all of these, but we really genuinely appreciate all of your interest. I think we covered quite a few of these. Here's a practical one. I'm having my 3rd primary vaccine. When will I need a booster shot? So how long after the 2nd dose is the current recommendation for a next vaccine? Perhaps, Jermaine, you're on the screen. What's your take on that?
Well, the current recommendation is between 2 to 6 months after the last dose of your vaccine. So that is what I recommend to my patients.
I wonder if that question, Toby, is about having a 4th dose after you've had your 3rd dose. Yes, and at the moment, there's no recommendation from a TARGI or anyone about that, but you'd imagine that there will be a recommendation at some point for a dose next year.
There's certainly lots of questions around that. Another question that's come through is, I'm fully vaccinated with AstraZeneca. What is the best for future boosters? So I think Steve touched on that before. Steve, do you want to just make another comment on that?
I don't think it matters which, just so long as you get that booster. If you had 2 doses of AstraZeneca and very little in the way of side effects, I'd be lining up for a 3rd.
Very good. Another good practical question here, which I might even ask of Greg. I know you're not a renal specialist, but 36 years post-renal transplant, I'm a nurse working in a regional hospital, ED and acute wards. Is it safe to continue? What's your thoughts on that?
I think that it is using the modern ideas that the 2021 ideas that have come through in terms of staff protection. The properly put on N95 mask is completely different for the staff than we were using a year ago. So I think that and glasses is sufficient for a staff member who's being careful. And in some ways, it begs the question a little bit about having better masks. One of the other questions was about a paediatric situation where you're worried about what should the family be doing. Well, again, if you're wearing masks for closer contact and stuff at times, or visiting someone, the better masks that fit tightly are better than the ones where the air could just blow in and out. So I think there's still a lot to the basic preventative mechanisms that we've got.
And that feeds very nicely into another question that's come across, and I don't think we've got a good answer for this either, but the question is, I'm anxious about not knowing if someone that comes to my house has COVID-19. I guess from the States, in my state, we have no COVID-19, so I don't really know how to answer that. So again, I might ask Simone, because what your thoughts are about that and how you would reassure people, or what advice you would suggest.
Well, I think people will have to ask about vaccination status. And if somebody's not immunosuppressed and they've been vaccinated and then they have the booster 6 months after their second dose, you can be reasonably confident that they're not likely to carry COVID in, as long as they don't have symptoms. As was mentioned, you can still get COVID if you're vaccinated. That person may not get very sick, but they're still likely to have some symptoms. And again, if there's a surge, then we should be cutting down people coming to our home. But we've got to, we are going to have COVID in the community going forwards. And I think people have to still be sensible about that. But hopefully with the high vaccination rates, people will have that ring of protection around them. I wouldn't, as a transplant patient, I don't think be getting into crowds and hugging and kissing people too, soon, and not even maybe in the next couple of years. But keeping your distance, doing all the things that we've learned how to do, but still having, from a mental health point of view, I think we're all going to have to get back to having people in our home, but keeping things safe through the things I've mentioned. It's going to be challenging. I think, a lot of people have actually embraced lockdown, and it suits many people's underlying personality and their concerns about their own health to stay away from everyone else. But I don't think it's good long-term for mental health. I think we will have to get back into socializing, but doing it safely.
That's a beautiful segue. I will show one data slide, so I'll share my screen right now, and hopefully, no, it's not going to work. I don't think. It's a pity, but what I was going to show was the data that we have that shows 100% of people who get healthy people who get vaccinated after 2 vaccines have got protective immunity against this virus, against the Wuhan strain virus. So Simone's absolutely right. If we get maximal number of people vaccinated, we will protect our transplant patients. Finally, Peter, you've got your hand up. What would you like to say?
Yeah, look, I guess the other thing that's about to change is the widespread availability of rapid antigen testing, which you can now get a kit in the supermarkets, in Coles and Woolworths, and I think we haven't learned how to use this technology yet. It's all we've heard about it is that it's not quite as accurate as the tests that we currently use, but nonetheless, it's going to be widely available. And I think particularly for people who are worried about exposure, I think that's going to be another level of testing, apart from a vaccination certificate, that I think we're going to see more use of that, these kits, and we're going to need to learn how to use and interpret these kits.
Fantastic. Thanks, Peter. So I'd like to hand back now to Holly for the end of the end of the webinar. I do apologise about the large number of questions that we haven't been able to address, and we'll be working with Transplant Australia to try to provide as many answers as we can on the website and potentially individually to people in the next few days. So Holly, would you like to take over and conclude the webinar for us?
Thanks, Toby. And what an informative and insightful session, excuse me, that we've had tonight over what the world that we're living in and what's occurred over the last couple of months in particular, but over the last 18 months in full. And the realities and the risks of COVID that we live with. But as Simone specifically said, you know, looking after our mental health is incredibly important, as well as the practical things that you can do, like getting vaccinated, having the people around you vaccinated, and looking after yourself in those personal protection ways like washing your hands, sanitizing, and wearing masks where possible. So those messages came across really clear. We hope that everyone listening was able to hear those messages and can, you know, and if they have any concerns for their own specific medical considerations, to talk to their specialists and to get as much information as possible. On behalf of Transplant Australia, though, I would like to thank Professor Toby Coates and the rest of the panel tonight. Transplant Australia is very pleased to continue their work with the TSANZ and keep the transplant community safe and up to date as much as possible. I'd also like to thank the team at Transplant Australia, Chris, Maddie, Kim, and in particular my fellow director and Transplant Australia Medical Director, Professor Richard Allen, for putting together this webinar tonight. Tonight's webinar will be, and the key messages will be shared on the Transplant Australia website very shortly. And as Toby mentioned earlier today, we do have another webinar in 2 weeks' time on Wednesday, the 17th of November for COVID vaccinations, and webinars specifically for paediatric patients and their families, which information on that webinar will be circulated tomorrow for everyone to opt in. So again, thank you very much for your time. Look after yourself, and we hope you have a really great evening. Thank you.
Thanks, everyone. Bye-bye.
Good night, everyone.
Night, everybody.
Bye.